Welcome, friends. This is Dr. Jaitly, your cardiologist from New York, on your favorite website, MuniMeterHealth.com. Yes, that's right. We are on several social media platforms, as you know. And obviously, our major theme, or the motto of our site, the educational site, is that we want to enhance our clinical outcomes in all our patients worldwide by improving the medical education as well as the patient education. And we have seen that the two components are so essential, because normally what happens is the doctors go out and attend their CMEs, come back, take the exams, and they're educating themselves. But we need to go back and educate our patients as well in order to improve the clinical outcomes. And that's precisely why I've created this website for everyone, not only for medical fraternity, but also for the patients in general. So thank you again for coming to MuniMeterHealth, and I'm glad all of you are associating, and this way I can now spend my time outside of the classroom and actually talk to you all over the world through this medium. So thank you again. Now, without any further ado, I'd like to delve into the subject matter. The matter of the subject today is: what are the new classes of drugs that have been just released for treating the LDL-C? Now, they've been around for a couple of years only, but obviously people are starting to familiarize more so, and we have 2 or 3 major prototypes in the market, and but the basic principle is that they are the PCSK9 inhibitors. Now, for a long time we knew about the statins, so we're not going to discuss the statins today, because that's been around for ages, if you will, and we had not had a huge breakthrough for a long time in the management of high cholesterolemia. Now, high cholesterol, when we are primarily considering the LDL, which is predominantly the portion of your ApoB, if you will. So ApoB protein carries the highest amount of LDL, and LDL is the culprit now, we know that, which is now responsible for all these plaque formations, if you will. So let's understand what a plaque is. A plaque is a manifestation which is macroscopically now understood at the age of 15 and onwards, that starts to develop within the arterial wall, and it chiefly in the endothelium, which is the inner wall of the artery. And as a result, if somebody has to see it microscopically or analyze it, it'll be composed of LDL particles. It could be composed of macrophages, where the LDL particles have been engulfed, and of course fibrin and platelets, because each time there is an erosion within the endothelium, or there is an extra layer that's formed. It's formed by fibrin and platelets, and then of course, which are present normally in blood. So normally the fibrin and the platelets should keep circulating as the flow is maintained. But fibrin and platelets tend to also accumulate here, and therefore the plaques are formed, and the plaques can actually increase in size, if you will, and further reducing the flow here. So now the flows, obviously the various vascular trees are important. One is the heart, second is the brain, third is your kidneys, and the fourth is your peripheral limbs. So these are your vascular trees, if you will. Important vascular trees only we are covering right now. So the carotids are important. Now, if the carotids get affected, then the patients can manifest as TIA or a CVA. We call it a stroke. Okay. Now, if the coronaries are involved, I've shown the coronaries here as they are the arterial supply to the heart. So in that case, obviously, the ischemia can occur, or an infarct can occur. Infarct implying myocardial infarction, which is heart attack, or this is ischemia implying that this is angina. Okay, so angina or heart attack both can occur, or MI we call it, MI. Now, renal vascular disease can manifest as well in form of chronic kidney diseases, or sometimes as hypertension, if you will, and that's called renal hypertension or secondary hypertension, which is a very important cause. So sometimes renal arterial disease can occur because of the same arterial plaques that are shown here. Okay, and then the peripheral arterial disease will manifest as claudication, where the patient is not able to walk too far without stopping. So then there will be fixed distances initially, but later on the distance will be shortened as the patient begins to exert. Sometimes he or she may not be able to walk up and climb or walk up a flight of stairs, and that may be the earliest sign where the vasculopathy within the peripheral arterial system is starting to develop in the lower extremities. And it's all because of this high LDL. It's also because of other cardiovascular risk factors. Do not forget that. The other cardiovascular risk factors, I have enumerated them here. One is obviously smoking, second is hypertension, third is diabetes, and then the overweight. So the LDL, which is high, or the HDL, which is low, they both contribute to this plaque formation here. But today we are discussing mainly the way as to how this new drug, the PCSK9 inhibitor, which we call it, has been involved. Now let's understand the LDL, which is constantly circulating within your blood volume. Now normally the LDL should not exceed more than 100. So let's keep it less than 100. If it is less than 100, you're in good shape. But if the LDL, now as long as you don't have high risk factors. Now today's recommendation, of course, we'll go over the guidelines at a different video state, but the fact is that the lower the LDL, the better is the flow, because LDL is a low density protein, but it tends to stick. HDL is a high density protein which tends to flow. Remember that. HDL is HDL is healthy, as I always call it, H for healthy and L for lousy. So L sort of sticks around, whereas healthy will just flow through. So you need more of HDL. More HDL and low LDL is better for you. Okay, just remember that. So that's very, very good. Now plaques can be mostly stable, or they could be unstable. So if they're stable plaques, then obviously they'll grow slowly within the vessel wall and continue to obstruct over a period of time, leading to ischemia or TIA or progression of renal disease. But if they're unstable, what happens is this plaque can actually rupture, and as a result, this may acutely obstruct, and therefore now you have a total occlusion. We call it TO. And that artery, when it obstructs, it leads to a heart attack. Okay, so a heart attack is a manifestation from a rupture of a plaque, or a thrombus that develops within the plaque, a clot that develops within the plaque, and that acutely obstructs the within any of these arteries. If it happens in the heart, it's called infarct. If it happens in the brain, it's called stroke. If it happens in the kidneys, it can lead to sudden kidney renal arterial occlusion. And likewise here, sometimes you may have a peripheral arterial occlusion within the lower extremities, and then that leads to the only way you can treat that is either by thrombectomy, where you can remove the clot, or sometimes an amputation may be the only way to actually treat the person. But what is PCSK9 again? So LDL is constantly flowing through your vessel wall. There are LDL receptors in the liver. Now here I've shown the liver, and the LDL receptors are like sponges. So each time the LDL that flows through the hepatic artery, the hepatic cells, they have lots of LDL receptors, and that's desirable. We need those LDL receptors, by the way. These are very, very good guys. So LDL attaches to the LDL receptor. It's called the mating, and as a result, some of the LDL will be removed, because now, as the artery is moving, as the blood flow is going through the liver, some of the LDL will combine into these receptors called the LDL receptors, but some of it will come back into the blood, and a lot of it will be thrown into the bile, if you will. So LDL, the way the liver tends to remove the LDL is by these LDL receptors. So, and then the receptors come back and the receptors are again free for more LDL to come back. So this cycle continues. So in other words, we can have our LDL constantly removed partially, and then receptors, and then the receptors are free, so that the LDL is removed by the bile, and some of the LDL, of course, is returned back to the blood. But there is another third guy. Now remember that this is the bad guy, PCSK9. Now here's the dude, I call it, and the PCSK9 is the one which actually gets involved with this LDL receptor mating, if you will, and that threesome is very, very dangerous. Now you have this so-called dangerous threesome where you have the PCSK9 and the LDL receptor as well. That is very, very dangerous, and you don't want that scenario. So the higher the PCSK9, the higher is the CAD. Remember, high PCSK9 leads to high amount of coronary artery disease or vasculopathy or any other manifestation, if you will. Okay. Now the lower PCSK9 will lead to lower CAD or lower vasculopathy. We're just taking the coronaries as a prototype here. That's why we're discussing CAD, for instance. So the whole idea is wanting to see if you can actually lower the PCSK9. Now, you cannot lower the level, but you can inhibit this. And how do you inhibit this? You inhibit this by a monoclonal antibody. Now, that has been developed, and of course, the classical example I'll give you is evolocumab. So EVOLU, and then of course MAB, evolocumab. And so this is a classic prototype, which is a great drug right now that is now being evaluated now worldwide and being prescribed, and it's been approved after the statins only to treat patients with for high LDL. Now you have to have 2 or 3 criteria here. One, you have to have an LDL which is extremely high. So one, you have to have an LDL of about 190 and above. 2, you may demonstrate that there is a premature CAD, like that means at the age of 35, 40, somebody is starting to have coronary artery disease or vasculopathies. If that is present, then obviously that becomes an indication. 3, the LDL is not responsive to the routine statins. So routine statins are not working. In other words, you're maximized on routine statin therapy, then you can prescribe this PCSK9 inhibitor called evolocumab. So those are 2 or 3 major indications. And sometimes you can also demonstrate an a PCSK9 gene, PCSK9 raising gene, if you will, defect. So what happens is PCSK9, this is an LDL raising gene, if you will. That LDL raising gene, if you can define this gene defect, then also you can prescribe it. But seldom that is done. But normally everybody looks at the premature coronary artery disease history, and then of course the LDL that's not responsive to statins, which is very, very important. And then the LDL, if it is more than 190, then you strongly suspect a heterozygous familial hyperlipidemia. So this is a heterozygous variety. Now, there is a very rare form where the LDL could be more than 400, and that is very, very rare. It's 1 in a million, and that's the familial homozygous type. So that is very, very rare. So don't worry about that. That's autosomal recessive. Excuse me. So what you're looking at is heterozygous variety. Pardon me. And the LDL, which is less than 190. More than 190, that's a great suspicion, and a premature CAD as well. And these are some of the suspicions. But anyway, I thought I'll just do a quick rundown on the PCSK9 inhibitors, which is a newer class of drugs which have just emerged since only a past couple of years, and now increasingly being prescribed. Increasingly we are recognizing more and more about this LDL, and we're starting to address, because we know LDL is the huge problem, and therefore we want to bring that LDL down. The faster you can bring down and the lower you can bring down the LDL, the better it is. In fact, now the criteria for LDL is less than 55. It used to be less than 70 only just about a year ago. Now with the newer guidelines from American College of Cardiology and American Heart, we have LDL which can be even dropped down to below 55, which we'll discuss on a different video. All right. Thank you again for watching MuniMeterHealth, your favorite site for learning, both for medical fraternity as well as for patients at large. And the whole idea is wanting to see if we can improve the clinical outcomes on one patient at a time, saving 1 million hearts. That's our prime goal. And thank you again. This is Dr. Jaitly. So long.